Good afternoon. My name is Xavier Llor from Yale University. I'm a member of the steering committee of the National Colorectal Cancer Roundtable, and I'm glad to be the moderator of this session today. The last stretch already there of the NCCRT meeting 2020. Our session will be on state-based colorectal cancer screening updates and innovations. And we're going to be really covering policy and practice implementation at the state level. And we're going to dig a little bit in the grant-funded programs, policy successes, and state-based coalition building efforts to improve colorectal cancer screening. As all you know, it does take a village, and we'll definitely see how all this unravels. We have an excellent panel who's joining us today for this meeting. First, we have Amy DeGroff. She's a senior health scientist at the Division of Cancer Prevention and Control for the CDC. And she will give us an update on the CDC's Colorectal Cancer Control Program. It's been 15 years since that got started, so we're really eager to learn where we stand and what knowledge we've gained from all that. And then we'll move to Lance Barbour, Senior State and Local Campaigns Manager of the American Cancer Society Cancer Action Network. And we'll hear about an update on colorectal cancer advocacy. We'll then move on to Molly McDonald. She's Director of Advocacy for Fight Colorectal Cancer, and we'll hear more from this organization and the Catalyst program. And finally, Donald Warren, Associate Dean of Diversity, Equity, and Inclusion, and Director of the Indians into Medicine and Master of Public Health programs at the University of North Dakota. And he'll give us some insights on the understanding and responding to COVID-19 impact on colorectal cancer screening in North Dakota. So I'm going to pass it along to Amy, and at the end of all the presentations, we'll be happy to take entertain all the questions and comments.
Thank you, Dr. Llor. Again, I'll be sharing updates from CDC's Colorectal Cancer Control Program. Next slide, please. Next slide, please. Thanks. We have just completed the third cycle of CDC's colorectal cancer screening programming. The most recent 5-year cycle, which we call DP 15-1502, ended in June of this year. Next slide. The tenets of our current model are noted here. The program involves our awardees, many of which are state health departments, integrating public health strategies within primary care settings that serve high-need population. A focus on evidence-based strategy is intended to maximize our limited public health dollars, and a focus on implementing health systems change aims to ensure sustainability. And finally, the collection and use of high-quality data are fundamental to the model. Next slide. This diagram illustrates the collaboration between our awardees and their partners with primary care clinics to implement the evidence-based interventions, or I'll refer to them as EBIs, to increase screening rates. We prioritize 4 EBIs recommended in the community guide, including patient and provider reminders, provider assessment and feedback, and reducing structural barriers. And all awardees are required to submit data for each of their clinics to CDC. And the data I'll present next are based on that clinic data set for the 5-year program that just ended. Next slide. So you can see here that the reach of the CRCCP was substantial, with 831 clinics serving over 1.3 million patients aged 50 to 75 participating. Next slide. And those 831 clinics were recruited over the course of those 5 years, with nearly half recruited in the first program year. Next slide. As I mentioned, the CRCCP is intended to serve high-need populations, and over 70% of our clinics were FQHCs, with a relatively low average baseline screening rate of 43%. Next slide. In regard to screening rate change, among the 295 clinics reporting screening rates at baseline through the first 4 program years, we observed an increase of 12.3 percentage points. That increase is substantially greater than increases seen for FQHCs nationally or for the country overall. Next slide. This slide shows increases in screening rates based on the number of new EBIs implemented. With each newly implemented EBI, you can see we find a greater increase in CRC screening rates. So for instance, among clinics, and this is looking at that far right column, that implemented all 4 EBIs, and that means that they had none in place at baseline and implemented all 4 of the priority EBIs during the course of the program, their screening rates were increased on average by nearly 27 percentage points. Next slide. So what drove increases in screening rates in these clinics? My colleague, Dr. Krishna Sharma, a health economist, has led several analyses that provide us some important insights, and we have the benefit of a big data set to look at these things. So first, we've consistently found that implementing 3 to 4 EBIs, whether putting brand new EBIs in place or enhancing those that were already there when the clinic was recruited, is significantly associated with greater increases in CRC screening rates. That enhancing existing EBIs leads to greater screening rate increases suggests that the quality of implementation matters. In addition, we found that what the community guide refers to as multi-component EBI implementation is also associated with greater screening rate increases in the CRCCP. So for instance, when you pair a provider-oriented strategy like provider assessment and feedback with one focused on increasing community demand, such as patient reminders, you get better results. Further, and not that surprisingly, we found that greater increases in screening rates are achieved among clinics with lower baseline screening rates when compared to clinics with higher baseline rates. This is basically the low-hanging fruit hypotheses where there's simply more room for improvement. And finally, we've repeatedly found that having a person within a clinic who champions CRC screening makes a difference. Next slide. During the last 5 years of the CRCCP, we also conducted some qualitative case studies, and one lessons learned includes the importance of providing seed funding to the clinics to support their participation in the program. Additionally, we found that assessing clinics when they're recruited in order to understand clinic workflows and identify potential EHR problems helped awardees to meet clinics where they are. This informed how and what technical assistance was provided and the selection of EBIs for implementation. The case study results also point to the importance of champions in leading health systems change. And finally, integrating the program efforts, the EBIs, into existing clinic practices seems to reduce burden on staff and patients and support sustainability. Next slide. So overall, I think we believe that this program can have a significant impact given its reach and effect on screening rates. And on this slide, I've summarized the main lessons learned, lessons that we've tried to integrate into our newest 5-year program. Next slide. This past July, we funded 35 awardees for the next 5-year CRCCP. 19 of these had been part of the previous funding round and 16 were new. These include state health departments, universities, tribal organizations, and other organizational types, including an FQHC and a primary care association. Next slide. Based on our experience and evaluation results, we're emphasizing some particular activities for this new set of awardees, including conducting a thorough readiness assessment of every clinic, thoughtfully planning for how implementation support should be delivered and identifying the best partners to provide TA to clinics, implementing multiple EBIs and identifying champions early on. In the last round of the CRCCP, we found that clinics struggled to find resources to pay for follow-up colonoscopies. Therefore, CDC is now allowing that some program resources be used for that purpose under this latest initiative. And in terms of measurement, we're asking awardees to not only report clinic level screening rates, but also to report fecal kit return rates and colonoscopy completion rates. And monitoring these two rates will help clinics identify areas for intervention that will, in the end, ensure that patients receive complete screening. And finally, we know that our grantees and our clinics are facing enormous challenges with COVID-19. That's just the reality for all of us, including this new program is launched. And we know that it will impede our implementation to some extent. We just want to provide the most flexibility possible to our grantees at this point. And we all hope that 2021 brings us better times. Next slide. I'd like to thank everyone today, and I'll pass the podium on to Lance from ACS. Thank you.
Thanks, Amy, and good afternoon, everyone. My name is Lance Barbour, and I have the privilege of serving on ACS CAN's state and local campaign team. Today, I'm going to share some policy successes we've had this past legislative session. We all know the challenges that COVID has created when it comes to patients receiving timely screenings. It has also thrown a wrench in some of the legislative work we do as well as it relates to colorectal cancer. As you can expect, we have had several state efforts focusing on colorectal cancer stalled, not because of issues with the policy itself, but more so because of a lot of legislative sessions and states focusing their, or shifting their focus, over to responding to the pandemic and also budget-related items. You can go to the next slide. Despite these unique challenges that 2020 has placed on the legislative priorities, we did have several successes around the country. One that I'll kind of get into a little bit more detail is Indiana. They were able to reduce their screening age to 45. Even with the budget issues the state was facing or will come to face as a result of COVID. This was a big win, especially when, USPSTF we weren't really hearing about any new draft guidelines coming out at the time. But so even other states even with facing the budget issues, were able to get some key appropriations for their screening programs. South Carolina was able to get, $1 million, Kentucky, $500,000. And this is not an exhaustive list. This is just a list of states that ACS CAN worked in to help get those passed. Next slide, please. One success I want to pull out from the previous slide, as I stated, was Indiana. So since 2000, Indiana has required insurance plans to cover colorectal screenings in accordance with ACS guidelines, which at the time was 50. As we all know, ACS updated their guidelines in 2018, which required the state to do so as well in Indiana state statute. Next slide. So hopefully the slides will be shared with everyone, but here I included the link. So if you want to take a look at the actual language of the bill that passed in Indiana, there it is for you. So one-stop shop will show you kind of like the transformation the bill went through the legislative process. The bill actually made it through the process with very few hiccups, which anyone that follows policy understands that is a rarity. And since my time is limited, I won't go into a lot of detail of what the bill had in it. But I did want to highlight the success of our Indiana team led by Brian Hannon, who's our government relations director there. The bill received just a total of 5 no votes throughout the entire process, which is really unheard of. So we were able to work with both Democrats and Republicans to get this legislation passed, and I think it just creates more of a robust conversation amongst legislators when it's more of a bipartisan approach rather than something that seems a little bit more partisan. The governor signed this on March 14th. And the bill actually was implemented and took effect on July 1st of this year. Another thing that rarely ever happens is states move quickly to implement laws that were passed, especially one of this magnitude. Usually you would see most states wait until January 1 for this to be implemented. So that was a huge win for Indiana. And again, like I said earlier, as you all can recall, USPSTF had yet to update their guidelines. So, individuals between the ages of 45 and 49 in Indiana were still subject to, weren't able to get those screenings without any cost sharing. And so we know that this is also huge because even with the guidelines being finalized, we're probably not looking at an effective date until 2022. So this, for all those Hoosiers, this is a huge win for those individuals between 45 and 49. Next slide, please. But we still have a lot of work to do at the state level across the country. As you can see here, not all states reference USPSTF or ACS guidelines in their statutes, and there are several states that don't even have specific language to CRC screening on the books. So, if you have questions about sort of where your state stands, where your statute is, I highly recommend you reach out to your ACS CAM colleagues in the state. They can definitely help you figure out kind of where you are. And then also who will be speaking after me today, Molly McDonald, who can also point you in the right direction with Fight CRC as well. Next slide, please. So here's a list of things ACS CAN is looking to do in terms of 2021 priorities and beyond. As I've stated earlier, we are in a tough budget. We're going to be coming into a tough budget situation in 2021 with a lot of states realizing the shortfalls that the pandemic has caused. We have to protect every flowing dollar into these programs. Many states will be looking for areas to cut, and with screening and utilization possibly being down because of the pandemic, we have to ensure that we at least recover level funding for 2021, because much like the pandemic has shut down everything around the country, we know that cancer doesn't stop, and colorectal cancer won't stop, and it is very important that these individuals have access to these screening programs. Several states, including Rhode Island, is looking to address the follow-up colonoscopy issue if a non-invasive screening is done, or stool-based screening is done, and a polyp is found, and it comes back positive. Then we want to make sure that that's a continuum of the screening process, and individuals aren't getting hit with a copay or cost sharing as a result. And Rhode Island is another one of those states that had built up a ton of momentum coming into this year and trying to get that piece of legislation passed. But unfortunately, with the shutdown of their legislative session, a lot of their focus had to be shifted. And so, and then at the federal level, ACS CAN will continue to push for the passage of the Removing Barriers to Colorectal Cancer Screening Act. And of course, we'll be keeping our eye on the USPSTF updated guidelines and when those will be finalized. And so, and we know that there's a lot of activity in the states outside of Big P legislative policy that's happening, where partners are working with health systems or different system changes. Please reach out to ACS and ACS CAN staff. We definitely want to be a part of those conversations and help move the needle along. So with that, I will turn it over to Molly McDonald.
Great, thanks, Lance. Great job. As Lance mentioned, my name is Molly McDonald, and I am the Director of Advocacy for Fight Colorectal Cancer, which, for those who are not familiar, Fight CRC is a national patient advocacy organization dedicated to supporting high-impact research, patient support materials, and policy change. Next slide, please. So before I started, I also just wanted to thank everyone for being here and sticking with us, and certainly to NCCRT for pulling off a wonderful virtual event. It's no easy task, and certainly Caleb has a newborn at home, so all the more of a feat. And hopefully next year we can all be together in person. But So today I'm going to talk a little bit about our Catalyst state-by-state advocacy program. So we launched the Catalyst program about a year ago with the goal of really supporting state policy efforts towards increasing access to colorectal cancer screening. And so we were able to launch the program with support from Exact Sciences, and we've worked closely with ACS CAN and the Prevent Cancer Foundation and CDC in sort of building up and building out the program. And so specifically our goals have been for the previous year, ensuring coverage for colorectal cancer screening beginning at age 45 in accordance with ACS and now USPSTF draft guidelines. And also removing out-of-pocket costs for patients needing a colonoscopy following a positive non-invasive screening test. And so Fight CRC provides grant funding of up to $50,000 to state coalitions who are looking to advance both Big P, as Lance talked about before, sort of that traditional legislative approach, Big P policy, but also small P policy. So, you know, working with insurers or employers in the state to have them change their policies internally to increase access to colorectal cancer screening. And so in addition to funding, we provide a professional facilitator to walk the states through a really robust action planning process. And so this was really something that was important to us as we built out the program. We wanted to kick off the grant cycle with the opportunity for grantees to really think about who needs to be in the room and who are the key stakeholders that will help get this effort over the finish line. And then have some dedicated time to brainstorm and talk about our goals, and what it's going to take to get there. And at the end, states are able to come out with a fleshed out action plan that can help them implement these changes over the course of the grant cycle. And in addition to that, we also provide technical assistance and a number of resources, most of which are housed on our advocacy portal. So if you visit fightcrc.org/advocacy, we've built out an advocacy portal that we really intend to be a one-stop shop for folks looking for information on colorectal cancer advocacy at both the state and federal level. So on that site, you can find one-pagers on all 50 states. So some of the information that Lance mentioned in his presentation, kind of a snapshot of the screening landscape in your state. Also a sense of does your state have a colorectal cancer screening statute? If so, does it reference USPSTF? Does it reference ACS or perhaps another organization? And in addition to that, we have one-pagers on our legislative priorities. We have webinars with folks in states that have been successful at passing colorectal cancer policy. So we were fortunate enough to work with folks from Maine and Indiana, as Lance mentioned, and Kentucky, to have them come on to talk for 20 or 30 minutes about the experience in their state, what challenges they faced and how they overcame it. And I think that aspect of the program is also something that's really important to us. Our goal ultimately is to be able to expand to all 50 states. Obviously, that will take some time, but in the meantime, we really want to create, an environment where states can come together and share best practices. We can develop models so that if a state is looking to, get into colorectal cancer policy work, they have a place to come where they can find resources, where they can, connect with other folks that are doing this work. And so we can really sort of spread the wealth in that sense and keep colorectal cancer policy a priority at the state level. And so in year one, we provided funding to Arkansas, California, Colorado, and Louisiana. And so those first states, Arkansas, California, and Colorado, are pursuing a traditional legislative push, working on the issues that I discussed earlier. Obviously, again, as Lance mentioned, this was a challenging year, to say the least, with COVID. State legislatures largely shut down in March due to the pandemic, and so that really put a pause on legislative activity. But despite that, we were still able to really make some great progress, and I'll talk a little bit more about that shortly. Louisiana is pursuing what we call a small p policy approach. So they're working with some of the largest health insurers in the state of Louisiana to get them to implement pilot programs, particularly around the follow-up colonoscopy issue. And so our hope is that from that we can develop case studies of one, how to engage and interact with perhaps your employer or your insurer around these issues, but also to show that for future legislative action that this is something that is worthwhile. And so the last thing I'll just add before we move on to the next slide is we also created a Catalyst Advisory Council, which Lance is a member of, in addition to representatives from Prevent Cancer Foundation and the CDC. And they really help us steward the program, and they've helped us review applications for grantees as they've come in, and also help us sort of troubleshoot challenges and think through as things evolve. For example, as USPSTF comes out with their new guidelines, how do we pivot with our legislative priorities, and how are we thinking through the areas of needs in the state. And so I think it's been a really great way for us to, strengthen our partnerships with folks in the colorectal cancer community, and again, really make sure that we're not recreating the wheel and not duplicating efforts, but instead being able to work together and support the work and leverage the work that's already happening at the state level. And one last thing I'll add, I promise, on this slide is that we also recently awarded our year 2 grantees. And so we're really excited about that, and we'll be working, we're having our official announcement of them tomorrow, but we are working with Kentucky, Rhode Island, Nebraska, and Texas in year 2. So we're really looking forward to that. Next slide, please. So one of the, I'll say, silver linings of COVID was that, since things in the legislature really did slow down, it gave us a moment to sort of take a step back and pause and think through, okay, what can we do to use this time wisely to, support efforts around policy at the state level. And so we partnered again with ACS Prevent Cancer, and with NCCRT to host state policy action planning sessions around our 2 legislative priorities. So this one, as you can see, is around lowering the screening age to 45. So we hosted this back in August, so obviously before the draft guidelines came out. But I think many of the lessons learned and sort of the trends that we identified here still hold true, even with the potential change, or with the change on the horizon. And so we brought together a small group of folks who have been doing policy work at the state level, public health professionals, researchers, and we kept it fairly small because it's Zoom, and it's hard enough to be on Zoom and to get everyone able to talk. But again, we really wanted it to be a discussion, and for us to really dig into areas that we could work together. And so this is just a snapshot of what came out of the sessions, and we have full executive summaries that I'm happy to share with folks. But in terms of some best practices that came out, the patient stories and using the patient stories to illustrate the policy ask is paramount. And so I think, Fight CRC, we've really made an effort to make sure that we're bringing patients into this work and helping to empower them to tell their story and really bring a face to these policy efforts. Another thing that repeatedly came up was the need to work with a high quality government relations professional. Funding is incredibly important, but also to be able to work with someone at the state level who has expertise in your state and your legislature is can really help boost your efforts. And another piece was developing a targeted public relations strategy, including social media. And so I think this is perhaps even more important in light of USPSTF's recent announcement. I think even when they do finalize that guideline, there's going to be a real need for education and awareness around the guideline. And so thinking through a public relations and social media strategy that would be effective for your state and for your population will be incredibly important. And so in terms of next steps that we identified from the planning session, a couple of things really kind of floated to the top. One was around economic data. As you'll see in the next slide too, this is something that repeatedly comes back with our policy asks, both at the state and federal level. There's just some legislators who really want to understand potential savings associated with increasing access to screening, and if they were to put in place a particular policy, what would that mean for their state budget? And I think in times of our current times of COVID and the challenges that have arisen from that, it's more important than ever. Additionally, state-specific data. ACS has great national data that really paints a stark picture about the challenges and sort of landscape of colorectal cancer in the US, but also having that state-specific data so that policymakers can understand the burden of colorectal cancer in their state, in their county, in their district. It really helps bring it home for them. And again, I sort of touched on the education and awareness piece. Next slide, please. And so our second session was on coverage for colonoscopy following a positive non-invasive test. And again, many of the best practices were similar, but I tried to pull out some different ones for this slide. Again, identifying, patient champions and having them to tell their story, but also physician champions. And so that's something that in several states they found really helpful, is not only to hear it from the patient perspective, but also from the physician perspective. So, engaging those folks in your coalition is a really important piece as well. Another piece of it is, to not recreate the wheel, utilize legislation from other states as a model. There's many states that have passed legislation, some of which Lance talked about in his presentation. And so it may not mean that their exact legislation works in your state, but it's a great starting point. And more likely than not, if the legislation is passed, it's navigated some of the challenges that may come up. So it's definitely a good starting point. And also, I think this sort of goes without saying, but build strong state coalitions. Policy work can't be done with a party of one. And so I think the more broad your coalition can be, the better. And so looking to not only folks that are willing to weigh in with their legislators, but folks who can help provide data or stories or sort of, other pieces of information that can support your policy ask is huge. And in terms of next steps, again, the economic data is a huge piece, particularly for this follow-up issue. And something that Fight CRC is working on. We're in the process of partnering with a group out of the state of Arkansas that has access to claims data to help us really paint a picture around sort of the burden of this issue and what it might look like for the state. And so our goal is ultimately to be able to create a template for states to say, this is the data that's most impactful in telling this story, and this is how you package it in order to bring it to legislators. I think something that we've run into is that we don't necessarily need, a big peer-reviewed study, but we need something that is going to be in a format and in terms that is going to speak to a legislator that may or may not have much background in this issue. Another important piece, and particularly for this follow-up issue, is linking to COVID, and just really making sure that we can't ignore that COVID-19 is happening and that there's been a significant impact for state budgets and just states in general. And so grounding the issue in that. And then finally, just again, trying to develop a consensus statement across the colorectal cancer community. And NCCRT has done a great job towards this work, but just making sure that we're all singing from the same song sheet as we go into different state capitals. And I know I'm going over time, so I'll wrap it up, but look forward to a great discussion.
All right, thank you so much. Again, my name is Dr. Donald Warren, and I'm a family physician, and I'm also Associate Dean at the University of North Dakota School of Medicine and Health Sciences. And I'm also Director of the Indians into Medicine and Public Health Programs at UND. And I think the last presentation is a perfect segue to this discussion in terms of the need to build strong state coalitions and also to link these issues to COVID-19. So in North Dakota, we have this interesting convergence of several issues from a public health perspective. Historically, we have had disparities in higher incidence rates of colorectal cancer, lower rates of screening than the national numbers. And unfortunately, we also have higher rates of early onset colorectal cancer. In addition to that, we have some populations that are at greater risk. We have a significant number of American Indian population here in North Dakota. I'm Lakota myself, and I know in my communities, we tend to have higher rates of colorectal cancer, but also less screening and therefore later stage diagnosis. So over the last 10 to 15 years, there's really been a concerted effort here in North Dakota to try to do something about this. And I just recently served for 2 years as the chair of the North Dakota Colorectal Cancer Roundtable. And we've made some meaningful improvements, and we actually received a national award from the National Colorectal Cancer Roundtable, receiving one of the 6 National Achievement Awards for some of the improvements that we made. Next slide, please. Of course, one of the other challenges that we're facing in North Dakota, many of you may have heard this, but we have higher rates of COVID-19 as well in North Dakota. If North Dakota was a nation, we'd have the highest incidence of COVID-19 in the world. So we have a convergence of multiple issues that are going on right now. So we did conduct a survey of providers and public health stakeholders through our roundtable, the Cancer Coalition, and our state's Quality Improvement Organization. And the purpose was to understand the early impact of COVID-19 on colorectal cancer screening in our state, and to use that feedback to develop a state action plan for safely reigniting screening. Next slide, please. So in terms of the impact of COVID on colorectal cancer screening in North Dakota, 84% of the applicable respondents who did conduct screening said that they had suspended CRC screening at their facility. And on average, it was about 2 months of suspension of the screening. And again, the survey was conducted in August and September. And unfortunately, our numbers have worsened in terms of COVID-19 since September. So the recent numbers might be even worse than that. 75% of applicable respondents said that they were addressing screening through telehealth visits. So that's part of the good news, is that we're trying to expand utilization of telehealth. Of course, you can't do a telehealth colonoscopy, but there's a lot of things that we can do in terms of FIT and other stool-based tests. And also we found that there was a lot of need for training and support, including implementation of screening via telehealth, mailed FIT processes and procedures, and then safety precautions for screening during the pandemic. One of the respondents said that preventive screenings are very important for our facilities, but during the pandemic, preventive screening have kind of fallen off of the radar. Next slide, please. So in terms of some of the outcomes, when we look at challenges and barriers, 70% of the respondents said that they did have a backlog in screening, which is not surprising given the dynamics. There are also competing priorities, certainly with our staff, and the need to do more testing and tracing. 76% said that there were competing priorities during the pandemic. And 96% of our respondents stated that patients had a reluctance to come into clinic, and they were reluctant to engage in non-urgent testing or procedures. And those are the most severe impact in terms of COVID-19. There are also restrictions on capacity and scheduling, and to some degree, some changes in staffing and personnel that was having an impact during this time frame. Another respondent said that we have had many patients that do not want to come into the clinic or hospital because they are scared of getting sick. We've had to postpone and push back colonoscopies. Next slide, please. So at our recent Colorectal Cancer Roundtable annual meeting just last month, of course, held virtually because of the pandemic, we focused on colorectal cancer screening during the pandemic, and we had several breakout groups. It was very well attended, a lot of key stakeholders. And we discussed various considerations like public and patient messaging about screening during COVID-19, prioritizing patient populations. When we look at the backlogs in screening, as I had mentioned, we have some populations that are even more adversely affected by colorectal cancer. Also strategies for mailed FIT interventions and those processes, addressing CRC screening during telemedicine, and also data and policy implications. Again, I think ties very well into some of the previous discussions. And next slide, please. So in conclusion, just our next steps based on some of the input that we've received, we're planning for virtual professional education in response to the survey and in response to the breakout group feedback that we received at our annual meeting, particularly around mailed FIT, linking flu and FIT together, telehealth workflows, managing backlogs and screening, et cetera. Of course, right now, as you might be aware, in North Dakota, we're having this severe outbreak and worsening of COVID-19, even to the extent that the governor has asked that non-symptomatic COVID positive healthcare workers continue to try to work in the state. And so we're really under some really difficult challenges here. Also, we'll be partnering with our North Dakota Cancer Coalition and other stakeholders to promote messaging on the importance of cancer screening even during COVID, and maintaining a priority of improving access to colonoscopy after a positive FIT. And I'm very pleased that other speakers have talked about this, including Lance and Molly, recognizing that if you have a positive FIT, you're not done screening until you get the colonoscopy done. But how do we do that during the pandemic? So much of this is a work in progress, but really appreciate the opportunity to highlight some of the very direct challenges that we're facing in North Dakota. And I'll go ahead and pass it back over to Xavier. Thank you so much.
Terrific. Thank you very much, all. And we started getting some questions, and the first one relates to the coverage of colonoscopy for positive stool test, and where we stand at the federal level in terms of initiatives that would support that. And tagged to that, there was some response saying now the USPSTF is actually open to comments, and there'll be a time that this could be addressed through those USPSTF guidelines. And again, tagging to that also, I wonder if you can comment, Lance and Molly, on where we stand in terms of the Removing Barriers to Colorectal Cancer Screening Act, and what chances of success are with this new Congress.
Sure, I'm happy to start.
Go ahead.
In terms of the Removing Barriers to Colorectal Cancer Screening Act, so that's obviously something that we've worked on for many, many years. But this year we have enough co-sponsors in both the House and the Senate to have veto-proof majority. So that's pretty impressive. But of course, in January, we'll have to start over with the new Congress and reintroduce the legislation. I think we made a lot of progress in this past year, both in Congress and within the administration. And I think it's likely that this new administration is going to be friendlier to these types of issues. So I'm definitely optimistic that we'll be able to make progress with that bill and finally get it off the table.
Yeah, and actually, I mean, Molly, I think Molly hit the nail on the head. I really don't have much to add, but I will say that with the new Congress, we are much more optimistic that we can continue to push this ball up the hill, which seemed like, or this rock up the hill, to get it passed in the next Congress. So.
Another question, and that'll be for Amy, which I wonder if you could touch upon what, after all these 15 years of implementation of the grants from the CDC, what do you think have been the more critical aspects that really have helped success in some of the unforeseen failures? I wonder if you could comment on that.
Thanks for the question. Yeah, I think in our earlier models, when we started with the demonstration project in 2005 and our first iteration of a program in 2009, we were focused more on screening delivery in that model. And I think we found our impact, given the resources that we had at CDC to fund the program, were limited. And so I feel like our transition to this health systems change model, and I talked about the tenets of that model that support sustainability, that I think better use our resources. And I think based on our results, I think we see we're having a greater impact, that has been the right direction for us to go.
Sustainability has always been an issue, correct? And how we tackle that. There have been initiatives from even from the roundtable and the links of care and all those things. And again, those relied on having specific grants for patient navigation and all those issues. And when this money goes away, it's very hard for a lot of programs to really be able to sustain that type of engagement. So we can really and that really hampers the progress. So I wonder if you have any ideas on how we can make all this more sustainable.
I think your point about patient navigation is true. And in our program, while we prioritized 4 of the evidence-based interventions, programs could also implement patient navigation in clinics. However, because we were emphasizing sustainability and the 4 EBIs, we found much greater levels of implementation of those EBIs. And we find that they're more easily integrated into existing workflows and systems. So you can put a provider reminder system, make that part of the EHR system in a clinic. And once that's established and professionals are trained on how to provide a referral and that sort of thing, we feel that there's a good chance that they can be maintained once our seed funding to that clinic goes away. Navigation, of course, is really important. And I think we have to look at other ways for that to be reimbursed in a long-standing fashion, like through insurance or whatever, to help it become a more sustainable intervention, because it's so important to the hardest to reach populations that do have so many barriers to access.
I wonder, I have a question for Donald, which is, eventually COVID will go away, but I'm pretty sure that what we live through will change a lot of ways on how we are addressing a lot of things among them, colorectal cancer screening. Do you have any thoughts about this and how you see that overcoming?
I think for a very rural state like North Dakota, potentially one of the silver linings of this terrible pandemic is expanded use of telemedicine. So again, we can't use telemedicine necessarily for colonoscopy, but there's so much that we can do, I think, much more effectively in terms of reaching patients and promoting the use of other forms of cancer screening, of course, is vitally needed. And then just strengthening the telemedicine infrastructure can have a lot of other benefits, even above and beyond cancer screening, but just looking at overall access to services and improving some of the disparities. So I'm hoping that that's one of the outcomes of the pandemic, is that we will continue to strengthen our utilization of telemedicine.
Very good. And we have a question from the audience. Amy mentioned 4 EBIs that have the most effect when done together. Given COVID limiting the capacity of many clinics and coalitions, what is the one thing you suggest the attempt?
Well, I think actually any of these interventions, we don't have data yet to say this EBI is more effective than that EBI as part of our program. And I think, the context of all these 800 plus clinics vary so much that it would be hard to say. But I think, well, a couple things. 1, implement one intervention, and 2, get a champion in your clinic to promote colorectal cancer screening. I mean, there's tons of literature in public health to support the value of champions in affecting outcomes. And we have plenty of data for this program that champions are important.
Great. Thank you very much. I think we're almost out of time. I really want to thank the whole panel. It's been a very informative session. I really appreciate that. And ask everyone to go back to this event main session for the final words of this meeting. And again, thank you for being with us.